I'm Dr. Barbie Sullivan, and I'm one of the partners with the Women's Clinic in OBGYN. Mammograms are instrumental in the early detection of breast cancer. They're very important, and we've seen some big changes in the types of mammograms that we do that have been instrumental in helping us detect breast cancer even earlier than we used to be able to. We were the first clinic in town to put in the 3D mammogram, and we were really excited about that, particularly because of the advancement in being able to see dense breast tissue better. And the 3D mammogram definitely does that. So that's the only type of mammogram that we do, but we actually are one of the few clinics around that has a diagnostic center. So we do diagnostic mammograms and ultrasounds in our clinic. Becoming the patient, going from being the physician to the patient, is kind of an interesting transition. And I have done that in my life. I had children, and so I was an obstetric patient and, delivered a baby and learned far more, I think, than I learned in my 4 years of residency about, what it means to do that. But in 2019, I developed breast cancer. That was detected early on a mammogram, and I became a different kind of patient because not a really joyous occasion like having a baby, as you can imagine. So I had a mammogram just as part of my annual exam. The mammographer, because I'm here all day, came into my office and said, they just see a little something. Those are words that will strike fear in a woman's heart because the first thing your mind jumps to is, how can I, what if I have breast cancer? I mean, how could I have breast cancer? I mean, what if I do? And then surely I don't. I really don't have a strong family history, and I really don't have issues, had not had, any issues with any kind of breast findings or anything like that. It just wasn't really on my radar. I just did my mammogram every year as part of my annual exam because that's, what you're supposed to do. It's what the people who are a little bit smarter than me, what our college and what the radiologists say every year after 40, you come in and have your mammogram done. And so I do that. Then what happens, you go and you have what are called additional views. And so that's a procedure where you go and have a mammogram that really focuses in on a particular area in the breast. You have an ultrasound, and, I'm doing that as a patient, but with people who who I work side by side with every day. So that's kind of an interesting thing to go through, because you're just the strong doctor, And when that came back, the radiologist said, yeah, I think this really needs a biopsy. And so what happens next is you have what's called what I had was what's called a stereotactic biopsy, and there are different ways that biopsies can be done. So they can be done with the mammogram looking at the spot, and then you have needles that go in, and of course you're numbed up and you don't feel it. It's just kind of a weird thing to have done. Or you can have an ultrasound guided biopsy where they numb the spot up and use the ultrasound. But the important thing is that they can see the area that they want to biopsy. What I had were what are called microcalcifications. So those are probably the more difficult to biopsy. Dr. Schamberger numbed an area up, put my breast in the mammogram machine, and then they take 6 or 8 little needle-sized biopsies. So it's kind of a weird procedure. I mean, you're, chatting, and but your breast is in a vise. So it's, but I think going through that now, when I talk to patients, I can truly tell them exactly what to expect. Dr. Schamberger called me a few days later and said, it's a breast cancer. And I just thought, God, I was really hoping it wasn't going to be a breast cancer. That sounds a little bit crazy, but it was just like, I don't have time for this in my life, and it was really just not something I wanted to have to deal with. But we all deal with things we don't really want to have to deal with. Patients look at me when I tell them that I had breast cancer, and they're like, "You?" Because it's almost as if we have this halo, something around us that gives us that protective shield. But, it doesn't. We're human, and we get things that everybody else gets. And, we see breast cancer as, very young, all the way up to, women in their 80s and 90s. The younger a woman is, the more aggressive it's likely to be. I would say I would not be considered young at 55, 56, but probably a fairly average age to be diagnosed. My breast cancer was caught in a stage that is kind of strange. It's what you would call stage 0 breast cancer, or DCIS. It's kind of the latest you could possibly catch precancerous change to the very earliest you could actually catch a breast cancer. And this is where mammograms come in, because you can't feel microcalcifications. You just can't. So if I had waited another year or waited until I felt something, my situation would be completely changed. And what it gives you when you're diagnosed early is choices, I think. That's the biggest thing, is that you have choices. So I had choices that I could make. I could treat it with a lumpectomy and radiation. I could have a mastectomy and really not do anything else. I could have, a chemotherapeutic regimen and have a lumpectomy. So I had choices, and for my life and my lifestyle, I chose to have mastectomies, partly because the DCIS I had was pretty diffuse, and so I worried about recurrence down the road, and I didn't particularly want to do 8 weeks of radiation, and it's what worked for me. But I did have those decisions. When you get diagnosed later, you don't have those decisions. Here's your treatment path. It's going to be chemotherapy. You're probably going to lose your hair. You're going to, more likely to have recurrence, more likely to have more disfiguring surgeries and that kind of thing, multiple surgeries. So I think I was pretty lucky and that I was diagnosed that early, but that never would have happened without mammogram. So next thing, went to the breast surgeon. We talked about all of these options. And, as a physician, you're talking to another physician and somebody that you see every day. And so those become kind of interesting conversations to have. And I'm not a person who becomes a patient very easily. So I think at one point the surgeon told my gynecologist, she basically just told me what to do, which is not which is not necessarily true, but probably partly true. But I went in and had mastectomies and had a great recovery from that, was able to get back to work in about a month, and that's very important to me. I really don't enjoy not working, and everybody around me doesn't particularly enjoy me not working. So it was as seamless as it could be. It's a big surgery. It's a very big surgery, and it is a big recovery, probably more than I knew, but that's okay. I still made that right decision for me. But everybody has the right decision, and I tell patients that. Go in with your husband, sit down, talk to the surgeon, and decide what works for you, because, how lucky are you that you actually have some choices. I think it definitely makes me a better doctor, because you can't really have somebody tell you have cancer and not go to, at some way in your mind, to death. That's a possibility. That feeling that, people have, I just think I have a much better understanding of that. And so when I'm talking to when I call a patient and I say, your mammogram was abnormal, you're going to need to go to a biopsy, I know that they're thinking, the first thing you don't want to be pessimistic, but the first thing you think is, well, what am I going to do if I have breast cancer? And, what's my family going to do if this really, becomes a long-term treatment, or if it's, if it's not caught early, and or if it comes back. And so, I think it definitely has made me a better physician. I think probably in some way our staff were definitely impacted by, seeing the tough Dr. Sullivan, maybe cry and, go through the recovery. And I came back to work early, and so was still recovering. And yeah, I think it definitely impacted our staff in a lot of different ways. I worry about these last couple of years and women, postponing their appointments. I mean, we were closed for a time and did not do gynecologic appointments. And so then we started seeing people back, but trying to see our younger, healthier patients and that kind of thing, telling the older patients they still probably needed to quarantine. And so now that we have a system, and our office is very safe, and we are cognizant that people are coming in here that could potentially be exposed to COVID. And so we try to do everything that we can to protect our patients. But I feel like there are patients out there who have put off having their mammogram, may put it off 2 years or 3 years, and that's just too long. If you catch it early, if you have the right kind of mammogram and great radiologists looking at this, and, I could not ask for one piece of my treatment or one piece of this to have been any different. Like, do I wish I had somebody else who read my mammogram, or do I wish no. I mean, I got exactly the care that my patients get when they come in here, and I was thrilled with it. And I think if you've put off having your mammogram because of COVID, please come in and let us know that, because we can help you feel safer. But please come in and have your mammogram done, because it is important and it does save lives. This is an area that we really are learning a lot about. And over the last few years, the volume of mammograms that have been done in the country, the radiologists have noticed, initially we would say we have dense breast tissue that may cover up a breast cancer underneath it. But now we know that it actually may, by itself, increase your risk for breast cancer. And it's interesting because Dr. Reich, who did a wonderful video on this for us, and it's on our website, Dr. Reich was giving us a talk the week that I was diagnosed. And she put a picture up there of these just extremely dense breasts on mammogram. And my gynecologist looks over at me if she's in the same meeting, and she goes, "Those are your breasts." Like, and that really, truly is my only risk factor. I don't have a strong family history. I don't have other risk factors. I'm pretty healthy. I eat well. I'm not overweight. And so that really was my risk factor, was having dense breast tissue. And we're learning more about how we should follow that up, how we should follow patients who have dense breast. And we are staying right on top of that, because we know the importance of density in breast tissue and that link with the potential, with that being a risk factor for breast cancer. I'm Dr. Barbie Sullivan with the Women's Clinic. If you come in and have your mammogram done and it's determined that you have dense breast tissue, you'll get a letter in the mail from the Women's Clinic that says that you have dense breast tissue, and that's something that we are watching, and it may be a conversation that you really want to have with your physician on your next visit. We want you to understand that we are aware of that, and we are following that. In some patients, we are doing some different scans, like possibly an MRI or that kind of thing, but it doesn't apply to every patient. A lot of patients have dense breast tissue, but you do want to discuss it with your physician when you come in. So if you get the letter that says that you have dense breast tissue, we have very good information on our website that you can look up about dense breast tissue, and then we really encourage you to have the conversation with your physician next time you come in to see if you're someone who may need some kind of heightened screening. And I believe in the next few years we'll probably have some new way to screen people for breast tissue. The Women's Clinic has always been on the forefront of, we were the first to get the 3D mammogram in town, and if there's some new technology out there, we will strongly push for having that in our clinic also.